We have very distinguished speakers and panelists tonight. And the theme of tonight is the critical thinking for the low-value procedures in breast cancer surgery. Because we know that for the last 20 years, we're decreasing the limits of the surgery in breast cancer management, starting from the mastectomies to breast conserving surgeries. Now we're going more minimal after neoadjuvant treatments. And now then we started to do sentinel lymph node biopsies. And now we're thinking about whether to do or not a sentinel lymph node biopsy in certain cases. And now we come to an era that we have very significant and very good responses to neoadjuvant treatments. So what about de-escalating the sentinel lymph node biopsy or other kind of axillary dissections or axillary procedures in these patients as well? Also, one of the concerns in our daily life that we're surgeons, that we're doing oncoplastic surgeries that we are fond of. I know that many of you are fond of doing that, but are we doing or exaggerating our practice in here? So we have three distinguished speakers tonight. So in order, they will be talking about these three topics, and starting with Dr. Oreste Gentilini. He is the head of the breast surgery unit at San Raffaele Research Hospital in Milan. And he will be starting to give this lecture. But before that, I would like to give the microphone to Omar Sharif Omar. So maybe Omar, you would say a few words about tonight's meeting as well.
Thank you so much, Bahadir, for this lovely presentation. And again, Yazan always brings good from everyone. And we're quite honored to be collaborating and supporting Yazan in his activity. And let us get started so that we are not late. So I give you back the microphone.
Okay, thank you. Okay, so as it's written on the program, we don't want to be late about this. So Dr. Oreste Gentilini will be giving the talk about de-escalating sentinel lymph node biopsy in upfront surgery when may not be necessary. As far, maybe most of you know that Oreste Gentilini because he's the primary investigator of the SOUND trial and also the trial comparing the sentinel lymph node with the PET-CT in assessing the axilla, whether PET-CT would replace sentinel lymph node biopsy in future. So I'm so much impatient to listen to him. Okay, Oreste, the microphone is yours.
Thank you very much. Good evening, everybody. Thank you for the kind invitation and thank you for the introduction. This is the topic I've been given. So de-escalating sentinel lymph node biopsy in upfront surgery when may not be necessary. So I would like to start with this, I would say, vintage slide, one of the most projected slides ever. Everybody knows about it. It's the results published 10 years ago from the Z11 trial. Everybody are aware of it. So no difference at all in terms of disease-free survival and overall survival by omitting axillary lymph node dissection, even in patients with a positive sentinel node. So after this publication, several considerations and questions were raised. So the first one is very easy. We know this since the NSABP04 trial. So we know that surgery of the axillary nodes is performed not for a curative intent, but just for informative purposes. So if you want to say it in a more elegant way, so lymph node metastases are just indicators and not governors of survival. The second consideration is not so immediate to catch, is more subtle. And after the publication of this trial, the concept itself of sentinel node biopsy lost much of its importance. And this is why we all know that sentinel node was invented as a method to distinguish between two different types of let's say, patients, those with negative nodes who can be spared the morbidity of an axillary lymph node dissection, and those with positive nodes who theoretically might take an advantage by a larger surgical extent. But if this is not the case, then now we have the first question. So after the publication of the Z11 trial, we started questioning ourselves whether sentinel node biopsy is really necessary. And then we have another consideration, because we all know how much imaging is important in medicine, in oncology. And we also think or hope that imaging might play an important role also in axillary staging. And last, another consideration, we all know that at the moment, adjuvant treatment recommendations are more and more tailored according to the biology of the disease rather than on the risk of recurrence, as we can imagine by the nodal status. And therefore, we have another question. So the question is, will imaging might replace surgery? Can imaging take the place of surgery in this setting? And all these considerations and questions were summarized in this nice paper that I remember very with a lot of affect, because I wrote it along with my maestro, with Umberto Veronesi. And so all these considerations and questions led to the launch of the SOUND trial, which is sentinel node versus observation after axillary ultrasound. This is the meaning of the acronym, which is quite complicated, but still very easy to remember, international, and as I like to say, it sounds good. And this is the study design, very easy. So patients with small tumors, smaller than 2 centimeters, any age, just breast conserving surgery or therapy allowed, negative ultrasound of the axilla. And then we have the randomization between sentinel node versus no axillary surgery. The sample size, calculated sample size was 1,560 patients. What does sentinel node biopsy policy mean? Because at that moment, it was not clear. So by this policy, we meant that patients with micrometastasis did not receive axillary lymph node dissection, and patients with macrometastasis received axillary lymph node dissection within the trial. And we wanted to do so because at that time, at least in our country, that was the standard of care. And also because if really we wanted to, let's say, abandon sentinel node biopsy, we need to compare, let's say, the possible new approach, which is no surgery in the axilla, with the most radical approach on the axillary nodes. It's a non-inferiority trial. The primary endpoint is distant disease-free survival as a proxy of overall survival, but actually, obviously, we are going to evaluate axillary recurrences, disease-free, overall survival, the quality of life. It's important to take a look at the type of adjuvant treatment between the two study arms, and also some other numbers evaluating the performance of axillary ultrasound in evaluating the presence of metastasis in the nodes. So we started at the beginning of 2012, and we concluded accrual in June 2017 after randomization of 1,463 patients, which is approximately 94% of the sample size. So we were totally satisfied with this number. In the end, after some exclusions, we have 708 patients for both arms. These are the centers which participated. Just to say that the European Institute of Oncology, which launched this trial, enrolled about 45% of the patients, but 55% were randomized in other centers. And this is just a nice example of how we need to work closely together. So these are the features of the patients. So the mean age of the patient is 60 years. I'm sorry that I cannot show it with the pointer, but I'm sure that you can easily go through this table. So the mean age in both groups is 60 years. The ductal invasive carcinoma was, as expected, the most frequent type. The mean tumor size was 1.1 centimeter, and this was exactly what we expected because we selected patients with a tumor size smaller than 2 centimeter. And now we come at the nodes. So please take a look at the left column on your screen. And we can see that in the end, in the sentinel node biopsy arm, we had 13.7% of patients with positive nodes. 11.7% of these patients had just one positive node, and 2% had 2 or more positive nodes. If we go at the last row of this table, and we look at the same number from a slightly different angle, we can see that 13.1% had 1 up to 3 positive nodes, meaning that we missed a large tumor burden in the nodes in a very, very small minority of patients. So 0.3% had 4 up to 9 positive nodes, and 0.3% had 10 or more positive nodes. Concerning the feature of the disease, 6-7% had the triple negative disease, 6-7% had HER2 positive disease. So again, in the last row of this table, we can see that about 87-88% of these patients had luminal breast cancer. And again, some details on lymph node status. In the upper part of the table, this is what we probably missed in the observation arm of the study. So 5.1% had micrometastasis in the sentinel node, and 8.6% had metastasis in the sentinel node. We were not alone in this idea of evaluating the omission of sentinel node biopsy, because we had also similar trials in Germany, the INZEMA trial, with a very, very ambitious sample size, and they actually completed accrual. And we also had our friends in the Netherlands with the book group. Marjolein is the PI of the study. As far as I know, you are halfway or more than halfway, but you can probably update us later on. And the idea that we share in the UBreast group, along with Thoralf Freimer and along with Marjolein, is that we are going possibly to have a joint analysis of these trials, which have basically the same study design. This is just to say that we are going ahead with this idea of trying to compare imaging versus surgery. And now we have an ongoing trial evaluating or comparing sentinel node biopsy with an hybrid machine PET with MRI of the breast. So now, what I think, at least, is the real question at the moment is, how much information do we need in order to properly treat our patients? I have to tell you that when we started this experience in 2012, I was, let's say, a little bit more swaggering, but now maybe because I turned 50 now, I start being a little bit more cautious. And so there are some caveats that we need to take into considerations, because even though many things have changed in the last 10 years, but still the nodal status is important to take decisions. And we know that nodal status is important to understand which patients are going to take a benefit from extended duration of endocrine treatment after 5 years. Still, in some countries, at least in Italy, even though we have this very, very nice gene expression profile, but still nodal status is important to decide whether patients should receive or not chemotherapy. In Italy, only 2 regions have reimbursement for gene expression profile. So we hope that this is going to be improved in the next future. But at the moment, the vast majority of patients with luminal cancer do not have access to this test. For the small minority of patients who go for upfront surgery with an HER2 positive disease, it is important to know whether nodes are positive or negative in order to decide whether to give anthracyclines or not, or what type of anti-HER2 agents give to these patients, not to speak about the type of radiation fields. I hope that Marjolein doesn't mind if I take a couple of minutes to talk about this, because actually, to be honest, I feel more comfortable to omit sentinel node biopsy actually after primary systemic therapy. And that's why under the aegis of UBreast, we launched this trial. The chair of this trial are Toral Freimer, which is also the chair of the Enzema trial, and myself. And it's a very simple study. So it's not randomized. It's a single arm, like the, let's say, adjuvant paclitaxel trastuzumab trial, in which we are going to enroll patients with node negative disease at presentation. Only triple negative or HER2 positive breast cancer patients are allowed. These patients must have, obviously, primary systemic therapy, a complete radiological response, and a complete pathologic response in the breast. So in this case, we can omit sentinel node biopsy, and the sample size is 267 patients. So we had actually the first 2 patients in Germany. We are very happy about this. We just received the ethical committee approval in our institution, so we are going to start very soon, and we are going to coordinate all the Italian centers. Everybody who's interested to participate is much more than welcome, so please just get in touch with us so that we can hopefully increase the number of centers participating. And this is like my last slide. Bahadir was speaking before about this de-escalation path. We all have been walking about on this steep de-escalation path. And now I'm wondering whether we should continue or we should stop. Because actually my opinion is that probably we have reached the maximum level of de-escalation of surgery. The excellent results that we achieve at the moment concerning outcome of our patients is due to the careful, let's say, mixture of several ingredients: surgery, radiation therapy, medical treatment. And I don't know, maybe if we are going to omit one of these ingredients, maybe we might even worsen the outcome of these patients, even if we are going to increase the dosage of some other ingredients. So this is my last slide. I thank you very much for your attention, and I'm happy to take any questions you might have. Thank you very much.